Chapter 12, Predicting Immunotherapy Response, Laboratory Testing and Biomarkers.
One of the real challenges in cancer immunotherapy is determining which patients are best suited for immunotherapy and what drugs may be the most effective. I have to admit that our current understanding still leaves much to be desired in this area. One real hope is that with some of the intratumoral immunotherapy, understanding and predicting a response may become less important by providing low risk of side effects, with a higher success rate, lower cost, and less investment of time for treatment. Also, some of the intratumoral therapies are capable of driving an immune response, even when the markers and other tests are showing a less than favorable chance. One thing to keep in mind is that many of these tests and markers are dynamic and change based on the situation at hand. It may be possible to increase receptors such as PD-L1, often used as predictor to anti-PD-1 therapy. This means that a static test like PD-L1 staining done on tumor biopsy samples is probably not the best means for determining a potential response. In addition, the location of where the sample was taken in the tumor, whether in the center or the outer edges, can really change how much expression of PD-L1 that you encounter. Since PD-L1 is a protection mechanism of the tumor against an immune response, you might expect more to be expressed in the peripheral aspect of the tumor, because this is where immune cells would be engaging the tumor, but often biopsies are done in the center. In addition, new studies are showing that tumors may actually excrete PD-L1, which binds and inhibits immune cells, even at distant sites from the cancer. In a study published by Guo in Nature, August 8, 2018, titled, Exosomal PD-L1 Contributes to Immune Suppression and is Associated with Anti-PD-1 Response, they showed that tumors facing an immune attack can send out lipid-covered PD-L1 to suppress the immune response. As you can see, this is excreted, so it would not be reflected by the tumor biopsy. It is very possible a tumor could excrete PD-L1, but not express much on its own cell surfaces. In these cases, PD-L1 in the blood may be a new indicator of potential immune response to PD-1, PD-L1 inhibitors. At this time, this is not a test that is done to determine if a patient may be a candidate. It is issues such as this where I would suggest great caution in letting some of these tests dictate if a person is to receive therapy or not. Sadly, some people may be missing out on beneficial therapies due to limited testing available now, which may not always be accurate. These tests are currently being used in many cases to determine if patients' insurance will provide coverage for immunotherapy. This leaves many patients without the option to give immunotherapy a try, unless of course they pay out of their own pocket. Unfortunately, this may be necessary for a person to receive some of the more cutting-edge treatments. Additionally, most oncologists are sticking to the guidelines and would not be willing to offer it to their patients. At this time, the typical evaluation for a potential immune response includes microsatellite instability, MSI, mismatch repair, and PD-L1 receptor expression on the tumor. Microsatellite instability, MSI, assesses mutations in the DNA that occur from DNA mismatch repair. Sometimes, when the DNA is being copied, there are mistakes that occur, and typically those are recognized by the body and fixed. Just like mistakes in writing, you can have misspelled words, which result from incorrect letter, or you can have an entire misplaced word. When the cell cannot fix these DNA errors, you get an accumulation of many of them over time. The theory is that the more errors, the greater difference these cells would have from normal cells, hence they would be easier for the immune system to recognize. In colorectal cancers, tumors with high MSI, MSIH, have a better prognosis, probably related to the immune system's ability to detect them easier. However, Keep in mind this is not always the case. Renal cell cancers, for example, often have few mutations, yet still respond fairly well to immunotherapy. In many cases of cancer, the immune system may still naturally try to fight it and be losing, but if it is fighting, the cancer generally could not grow as rapidly, which results in a better prognosis. Also, in these cases, it is easier to stimulate these into an effective immune response if the immune system is already trying to fight on its own. Programmed death ligand 1, PDL1, is a membrane-bound protein that can suppress an immune response and protect against autoimmunity. This binds to the PD-1 receptor, and this interaction is the main target with some of the most popular immunotherapy drugs, such as Opdivo and Keytruda. As mentioned, testing of the tumor sample to evaluate expression of PD-L1 is used to determine potential success and often insurance coverage for treatment with this class of drugs. I think many of the hardcore researchers agree that this is not the most accurate evaluation, as patients whose tumor does not express PD-L1 may also respond, though typically with much less success. In addition, there are many aspects we do not understand related to these receptors. There is now a good indication that the timing of when these drugs are administered is important. Basically, you need to increase the initial immune response, the immune system's desire to want to attack the tumor first, then, in certain cases, follow up with PD-1, PD-L1 drugs to boost the response. If the timing is off, the immune response may actually be hindered. It is like starting a car. There is a sequence of events that must happen with fuel, compression, and spark plug ignition. If these happen out of sync, the engine will not start. This is still an area that needs more understanding, but again, intratumoral immunotherapy may help solve some of these issues, as previously mentioned with agents like TLR agonists. The TLR agonists seem to be important for getting the car cranked, while the other immunotherapy agents can remove the brake and step on the gas. Another test that seems to be helpful and certainly will become more widely used is Immunoscore, which was developed by Dr. Jerome Galland in Paris, France. The basic concept of this test is to evaluate the tumor specimen and the associated evidence of an immune response. Essentially, if there is evidence of more intense immune response, a so-called inflamed tumor, then the prognosis is better. This would be an Immunoscore 4. An immune desert, meaning an absence of immune cells within the tumor, resulting in an Immunoscore 0, has a poorer prognosis. This is essentially a new staging system, which does not depend on tumor size like the old standard system. Also, this test looks at both the center and outer edges of a tumor, which, as I mentioned before, is important because immune expression is often different depending on the part of the tumor sampled. The principle behind Immunoscore is very much the way I feel. As well, staging is based more on how your immune system responds and less on size, location, and the number of tumors. I think a new staging system should be developed, taking into account these immune aspects and also the overall tumor volume. In my experience, the more tumor volume, the harder the cancers to treat. We know that cancer produces substances to enhance its growth and suppress the immune system, so the more cancer, the potentially more powerful that effect may be. However, you could have an early-stage cancer patient that has more tumor volume than a stage 4 patient. In traditional treatments, the earlier stage patient would have the better prognosis, but with immunotherapy, you could argue that the one with less tumor volume may have the better prognosis. Certainly, a patient with less tumor volume and an inflamed tumor microenvironment should have a better prognosis than one with earlier stage disease that is an immune desert. We do believe that we can change a lot of these cases of an immune desert into a favorable inflammatory response within the tumor by the direct injection of immunotherapy agents such as TLR and STING agonists, thus leveling the playing field.